Hello everyone, my name is Rachel Moses. I'm a consultant respiratory physiotherapist and currently working in a Chief Allied Health professional role. And we've developed these series of podcasts to share our learned experiences of what's currently happening with the COVID-19 pandemic. So the usual disclaimer, the people that are invited onto the podcast, this is just their experiences, it's just what they've found. It doesn't mean it's right or wrong, it doesn't mean anyone's doing anything wrong or right. This is just what we've learned in real time. And I'm delighted today to invite Julie and Debbie onto this podcast, which is solely focused on psychology. So psychology of patients and the well-being of our staff. So Julie Highfield in the top left-hand corner is a clinical psychologist in intensive care based in Cardiff Intensive Care Unit. And Debbie down the bottom there is a clinical psychologist in intensive care working at Harefield Hospital in London. So welcome.
Thank you.
Thank you.
So I'm just going to kick off first of all by saying, why on earth do we need psychologists in the intensive care unit? I mean, these patients are sedated, they're paralysed, they can't communicate with us in that very acute phase. So Julie, if I come to you first, why do we need psychologists?
So that's the first thing that most people say when I tell them what I do for a living. They're like, how do you even get to work as a psychologist in the ICU, is the usual remark. And I think, the reality is a large number of patients are sedated and we can't access psychology for those patients straight away, but as they emerge, certainly their psychology can be really complex, and it's thinking about those patients as they emerge from the ICU, the first couple of days, and maybe the ward and follow up and beyond. ICU is a terrifying experience for most patients, so it's really the psychologist is part of a team of making sense of the unit for that patient. So it's about direct work with that patient where that's possible. A lot of the time it's working with the team, helping them to create an environment that's more psychologically minded and more comfortable for the patient. And it's about thinking about rehabilitation and follow-up, and as the person emerges from their ICU experience, how they make sense of it, how that impacts on their psychological well-being, and how we can kind of promote a better recovery. Then of course you've got psychologists who also are helping the team, so helping the team to work with the patient, but helping the team in their experiences with the patient as well, because what we see and what we witness in an average week in the ICU, some staff don't experience in an entire lifetime. So there's a lot of what we call vicarious traumatization, so witnessing the trauma of others is a very difficult and intense environment to work in for some staff. So psychologists being part of the team help teams to make sense of their experience and hopefully come out the other side without any negative impacts.
I mean, you mentioned the fact intensive care units are quite hostile environments, and I think what we mean by that is they're very clinical, they're very contained. On the newest intensive care unit, you might get simple things like windows, but for a lot of them, they're not designed to have kind of normal, I suppose, allow normal behaviours, because people are just in there because they're critically unwell. So to summarise, kind of, we've got a normal intensive care need for major post-trauma, post-surgery, if someone's acutely medically unwell, but now we're living in this COVID time where we have a new kind of patient population that are coming into critical care with much more different needs. And if we stay on the environment a little bit, and maybe if I come down to you now Debbie, the COVID critical care environment is even more challenging, isn't it, with PPE and masks and respirators, and how has that kind of impacted on your work or your findings?
I think normally the environment, like you said, is a challenge. So we've had to think about how these patients are going to get any sense of normality. And you would have seen on social media things like using faces on gowns just to try and humanise that person, humanise the people caring. So it's the basics. Our nurses, intensive care teams are absolutely fantastic at providing humanising care. And I think it's just the simple things like helping the staff really realise that they can still be as attentive, as caring. Touch is important, and facilitating a lot of kind of connection via video calls or video and technology, utilising that to connect with families as well, which again humanises the patient to the staff. And if the patient's kind of waking up, it allows the patient to have some connection with their normal life. All of these things are orientating. So we know that these patients probably are more disorientated than our normal ICU group, who are challenged already because they've been ventilated, sedated, they have drugs on board which are kind of altering their consciousness. So it's all of those things that kind of reconnect and humanize a person. It might just be simple things like they're making sure they've got a hearing aid in if they can't hear, or understanding the way that they see. So there was talk of people needing their contact or using contact lenses but needing visual aid. So just being aware of learning your patient's story enables you to humanize that patient and then adapt the way you're treating them, and that can support these people in COVID times.
You know, great point. So let's talk a little bit about the patient journey and how it may be slightly different then. So particularly for the patients that were coming in maybe 3, 4, well probably a lot longer weeks ago actually, if we think about the London population of patients. So they were coming, they maybe had heard of COVID, they maybe had heard of it in Italy, and then the patients who've been in intensive care over the more recent weeks would have known about the epidemic in the UK. So they've heard about this disease, and the next thing they might know is that they're waking up in intensive care unit having been critically unwell. So Julie, can I come back to you and talk about because as clinicians we might not really think, we might not have time to process this as a non-psychology or non-OT clinician. Even as a therapist, I probably don't understand this part as much as I should. So talk to us a little bit about that.
Well, I think what's really interesting and probably quite different for our COVID patients is that they were in this situation where they're very aware that this disease is around. I think, you know, there's lots and lots of stories and patients telling us, you know, coming out the other side of going down rather quickly. And being incredibly terrified. So they have that memory of that acute, intensively scary experience kind of coming in through A&E and having to be intubated. And lots of people, you know, have said about how in the A&E they were encouraged to ring their loved ones and FaceTime their loved ones just before being tubed as well. So really, really terrifying. Imagine that. It's just terrifying. And then what we're seeing at the moment is kind of two routes really. So earlier we've had some people who've come out and gone to the step down wards, and they've come out of the ICU relatively quickly, but their delirium phase has been really extended, and it seems like a kind of hypoxic subtype of delirium, and whatever I've seen that in other patients prior to this, they always seem to have the most vivid hallucinations and the most detailed delusions. So you're seeing that same kind of pattern there. And I think what's particularly interesting is that they're on formed wards a lot of the time. So rather than kind of what we would normally have, so you have the odd patient on odd wards and they've got the odd patient to deal with delirium, they've got sort of 15 patients in one go with delirium to deal with, and they're a newly formed COVID ward. So we've seen our nursing staff feel quite overwhelmed by that, and actually because of the PPE and wanting to, you know, people are still viral shedding, so they're still in PPE. The nurses are kind of coming in and coming out really quickly. And so the stuff Debbie was talking about, that kind of connection and that humanizing, they're missing that. So that's that one population we're seeing, and just how isolating all that is. Very terrifying at first, and then very isolating, and continuing to not have that reassurance. And then we have our other group who are waking up and remaining on the ICU because we're not able to wean them. So we're getting a kind of small cluster of long-term, well, sort of slower to wean patients, and that's been quite a challenge now, because kind of getting in and having a conversation with a lower level of PPE on a step down ward is quite possible. High PPE and psychology just doesn't really go together. You can't, with PPE you can't see facial expressions. I had a funny experience myself where I realized I'm a nodder, and actually my visor just kept bashing against my face every time I nodded, so I couldn't even do this kind of encouraging of conversation with a patient. I had to sit sort of rigidly still or kind of keep smacking my face. I got the angle wrong, and so the ability to connect is a lot different. And I think we're learning as we go, aren't we? And I think our MDT are particularly worried about this kind of cluster of long-term slower to wean patients, and what it's going to be like for them emerging out the other side, and how long it's going to take. Mm-hmm. So I think, compared to a normal ICU population, people typically don't have this background of prior knowledge, so the anxiety is really, really ramped up for them, and the disconnection is really, really ramped up for them, and it seems that the delirium is more prevalent than ever and harder to manage.
Mm-hmm. Debbie, can I come down to you, please?
Yeah, I think I echo Julie's points as well, but there's something very unique. You started off thinking about the story of these patients and the journeys in. This is something very unusual about this, because we were part of the North West London surge. So, and Julie, I think Cardiff had very similar kind of surges at the same time, where there would be multiple family members being admitted as well. So that was this has been really, really challenging. So, and I think that's still probably ongoing, less so now because the peak is kind of tailing off. But when you've got multiple family members who've gone to their local district general in an ambulance, maybe separately, one's got admitted to our unit, somebody else has stayed behind or become very unwell and unfortunately maybe not survived. You've got family members waking up in units who now need that news broken to them, who may be the one that survives, who may then have the guilt around that, or may not remember those kind of last few hours. We do find in follow-up, a lot of our patients will tell you a story of not really remembering the day before they were admitted to a critical care unit or even hospital. So you're having to kind of almost help people repackage some memories and also break some bad news at the same time. So it feels very unique compared to the last few years of critical care work that I've done. This feels like a really kind of key and very challenging part of the COVID story.
I think the other thing, I was just going to say about relatives as well, actually not getting the relatives in. So it's interesting, we haven't had as many multiple family members. We've actually had clusters of work friends, which has been an interesting one, actually. But I think it is interesting when we have had those multiple family members and the staff are kind of assuming, gosh, this is devastating for them, but family are very early on in their adjustment to this, and they're not necessarily wanting lots of help and support because they're in such shock with it. But that's another element of the connection, isn't it? Is that obviously visitors haven't been allowed except in extremes. We've actually managed to facilitate some family members in PPE to visit at end of life, and that's been useful. But it's the lack of getting your loved ones near and close to support you through this time is really hard.
So I just want to touch on, we talked a little bit about in a couple of our other podcasts about survivorship. Mm. So in terms of, anyone who has a severe critical illness and there is a high chance that person could die, and that person survives, it's the same in cancer surgery and outcomes. People should be grateful to have survived, and we generally find that people are very grateful to have survived, but then it's so much more than survival. And I think, is there a chance or potential, and we're very early into this in the big scheme of things in terms of recovery, that when people do get admitted, even on a ward for ward-based sealing of treatment, and their loved ones are told they will probably die and they won't be able to see them, and then they survive, survival should be enough. In the same breath, if someone's in critical care and they survive, that should be enough. Is there a worry here that a lot of deeper psychological issues might be missed because somebody doesn't want to come forward and say, actually, I am still really traumatized by this. I am so grateful to have survived, but I might not, I am still have all these feelings. Debbie, can I come to you and ask what if you've got any comments on that?
My view would be absolutely. We need to really pay attention to this time, because you've got an ongoing national story as well as an individual story. So we know that if a patient came to our hospital and they'd had a heart attack and they returned back into their normal life, we'd know that they would experience adjustment difficulties, but what they wouldn't have is a heart attack on the news every 5 minutes, or their next door neighbour then being admitted after them with the same condition, or this kind of story that runs through everybody's experience right now. So there's a potential for re-traumatization, or kind of dragging up some of the things that we naturally do just to get past it, get around it, survive it. We know people are inherently resilient, so we know that most people survive trauma, but the idea of post-intensive care syndrome and PICS is very established. We know that we've got to focus on those domains, and we won't quite know the prevalence rates for the mental health arm of PICS, or the cognitive arm of PICS, or even the kind of physical arm of PICS, really, let alone the family side yet. But we should anticipate that it's going to be much more of a challenge in this group, because also we're not going to be able to do the normal things that we do in a follow-up clinic. We're not going to see them face to face, probably. We probably won't be able to orientate them around the unit. We're going to try virtual reality and things utilising technology. But actually some of the powerful tools that we would use would be in vivo exposure, which is being back in the place where everything kind of happened. That might be a bit of a challenge. So I think even as psychologists, we know how we support people who are traumatized, but we're going to have to flex and bend with this as well. And we are facing that challenge too, but confident we can support people. I don't know what you would add, Julie.
I agree with everything you say. I guess what I would just add as just a little extra is that some people will have a delayed trauma response. So it's very common for people to almost seal over from their experience and not want to know and not want to connect. And I think that's why it's sometimes it's quite helpful from a follow-up point of view, especially more from a psychological point of view, is if there is almost the door is open to come back later, to enable people to come back later. So yeah, that's just another thing to think about, is it doesn't always emerge straight away.
Yeah.
So Julie, you've mentioned or touched on a couple of times what I would class as separation anxiety, or separation syndrome. So what never before in my entire career, and I've worked in infectious diseases, and have we never had relatives allowed into a hospital environment on such massive scale. Now, the engagement side of trying to get people to engage with rehab when all they want to do is see their loved ones, keeping people in hospital for rehab isn't really an issue, isn't really an option at the moment, for the obvious reasons. But these people just want to get home, and they want to get home in whatever kind of physical and mental state they're in. This is certainly what we're hearing. So is that a real thing? Like, how, when people are still in acute, how can we help address that? You mentioned some communication strategies, and identify it and relate to it, I suppose.
I think probably the way to identify it is to make the general assumption that most people need people. It's very rare that you have people who don't need people and don't want people at all. What's been interesting for us, so Debbie mentioned some of the things about kind of video calls and things like that, but what's been interesting for us is that we have actually had some patients where we've offered that and they've said, actually, I don't want that. So actually they've found, even though they miss their loved one, actually they much prefer to get through this phase and be in a better frame of mind. And you think about how it used to be, you know, in times before COVID, you might have people who are keen to have their wife there but not their work colleagues. So I think it's people need people, but it's how we give them that connection, really. It's interesting to call it separation syndrome. I wouldn't necessarily call it that. It's just more isolation and loneliness, actually, really, which we're all capable of experiencing. And even when you're surrounded by very kind and caring staff, it's still not home, is it? So I think it's very important for us to not label it, and to not make any assumptions about it, other than, can we create any sense of connection in the way that we work, in the way we are, in our approach, and where it's possible to get things like, you know, if you haven't necessarily got people video calling in, we've encouraged our relatives to write in, and we're reading letters to patients, and having things like photos and things like that, still having those kinds of things around that we then get rid of afterwards. So it's stuff that, you know, you know it's okay to lose potentially. So just simple stuff. It doesn't have to be complex. It's just about finding ways to kind of reconnect people with their lives. And as people become more cognitively able, the conversations we have about who that person is, beyond diagnosis, beyond whatever treatment we're doing, it's, you know, patients find it really great when you ask them about their pets, for instance, you know, simple conversations to see beyond the patient.
You know, Julie, a couple of really powerful things you've just said there that you may not realise, but it's getting people to think that, like, one model doesn't fit all. We say this in rehab all the time as AHPs and, you know, as therapists. It's really understanding what that person needs and what matters to them, and how people deal with any kind of tragedy in their life is so different, isn't it? Not just on learned behaviours, on personality, on your experiences, what you've been exposed to in the past, and this is no different. And I think this is where you guys come into your own, as the experts, if you like, to unpick that and help and support that, because sometimes as clinicians we just can't do everything. So Debbie, I want to come to you, and I know you might have a couple of things to pick up there from what Julie was saying.
Yeah, just the idea of, I echo the kind of connection. So you kind of said, how can we pick up on that, and how can we intervene? And I think Julie's answered that in terms of, you don't always need to, but actually finding out from the family. So we've had a few experiences on our end where actually it's been fascinating. We've been supporting the families more than the patients because they've been sedated. So their stories will be, oh, X doesn't actually like to talk, so I'm not going to video call him. He will be cross with me when he wakes up. I'm not going to do this, but actually I am going to send him X, Y, Z, and that would be really nice for him when he wakes up. So that is a relative feeling that they've got personal connection and agency, and that's facilitated through the team. So you're the ones, and we're the ones having those conversations with the relatives to help us understand that patient a bit more. In our trust, we've had a lovely scheme, which has been a knitted heart scheme. So actually there've been a pair of hearts. One has stayed with the patient and one has gone home to the relative. So that, again, there was another sense of connection, one within the unit and one outside. Sometimes just these really symbolic gestures can be so powerful for our families, and just knowing that we're giving patients that really attentive care by the bedside, holding their hands while they're on the video calls, or holding their hands when they're not very well or in pain. All of those basic things that we do promote human connection, promote our ability to intervene and support with that separation of a loved one. It's a big responsibility, and I think the nurses and some of the medical teams have talked about that a little bit, just informally around our unit. Feels like they are incredibly responsible for this person, but I do remind them that actually they were doing that already. Mm-hmm. This is no different. They probably do it with more patients now, ratio-wise, and they're still doing incredible work. Yeah, this absolutely. Is where the support of the extra pieces of the team have come in, those non-ICU professionals.
Yeah, and I think you've just touched on that. So we are hearing incredible stories from all over, the UK and the world, in terms of the care and compassion that's still being delivered in this pandemic. But actually, it's what we do. It is, this type of inherent caring and compassionate behaviour in an intensive care unit happens in normal times. I think the massive respect to the whole MDT for continuing to provide that. And there might be patients listening to this, there might be families listening to this, and I'm hoping that they are reassured that it's not just for the media, it's not just for people's social media. This is really happening inside every intensive care unit. Like we've never seen this on this scale and this level of kind of continued care delivery over weeks and weeks and weeks. And I suppose that brings us a little bit to the next section, which is how we look after the staff to continue to provide that. I mean, I am never amazed by teams that can continue to deliver hours after hours, days and weeks. But surely there must be some kind of impact for staff. And Julie, have you seen or witnessed anything in terms of, and this is a very delicate subject, I'm aware of that, but I'm sure you can tactfully.
Yes. So I'd like to give you both sides of it, actually. So we know prior to this that burnout is pretty prevalent amongst ICU staff, and I did my data earlier in the week, and I've had 3 times the amount of referrals for staff well-being as I normally would. So we know it's definitely had a massive impact on staff, but also I've seen staff really come into their own and experience great joy and great pleasure in the work they're doing. So I want to just touch on both, if that's okay. I think in terms of the impacts, what we saw certainly in the very, very early days was this rapid reorganizing, rapid getting your kind of ducks in a line, really, really working huge amounts of hours, and myself included, really trying to pull everything together and get things ready to go. And I think what I saw was this surge of energy with people, and I think we obviously had a surge of numbers with it, and kind of making errors and trying to, no, it didn't work this way around, let's do it this way around. We're learning things about these patients. So a lot of energy and joy with that, but also a real sort of sense of kind of exhausting yourself with that. And I think as it's sort of gone along, what we have now, it's great that we're flattening the curve, but what I'm seeing now is that staff have got tired with that. I think you could have elements that you could start to describe as being akin to burnout syndrome, but certainly in terms of the emotional exhaustion sides of things. There are other staff, however, who say that actually they feel like they've hit their stride with it now, so they feel like they've kind of relaxed into it a little bit more, and now the numbers are manageable and they can do that. I think a couple of other things to add in terms of the tricky side of things. We talked quite a bit about kind of relatives not being able to come in. We've certainly had some really traumatic things that we've witnessed when relatives have come in, and it's been worse for them because it's much more intense, that experience, when they actually do come in, and usually under very difficult and end of life circumstances. So there've been some quite traumatic things that staff have witnessed. I think staff in PPE, it's horrible wearing PPE, and it's sweaty, and it really affects your ability to do a good job, and you really have to pace yourself down and find your rhythm with that, and people's ability to kind of think straight and think clearly, both in PPE and the fact that actually all this is going on at home as well, so you can't escape it. You don't have your usual support mechanisms, and you can't go see your mom and dad or whatever, those kinds of things. People's kind of minds are really sort of narrow in a way. But what I would say to be more positive is, yes, that's hugely impactful and will continue, I think. But actually, some staff have felt like they've been able to do such a good job that they were meant for this. You know, there are so many staff members who said to me, don't worry about me, this is my time to do the best I can and be part of something. And I think that energy and that joy has really carried some people through as well. So just to see both sides of it, really.
That's so insightful, honestly, Julie. And I think I probably hadn't appreciated that other side as much as maybe I need to. So thank you for that. Debbie, I'm going to come to you.
I completely agree. It's been absolutely fascinating. I think from the beginning of the journey, I think the word moral distress was also talked about quite a lot, and the concept of there's going to be decisions being made, there's going to be a change in the way we make them, who's involved, how quickly we have to make these decisions, and what's going to be the impact of that. And I think that's definitely something for us to watch for, and to watch the impact as this journey goes along. But I've been amazed by the positive stories as well. And we know there's a concept of post-traumatic growth. So whenever we're put in a pressure cooker, we can come out the other side soaring. So I think our ITU have talked about an increase in numbers of job applicants coming their way, increasing. I think sometimes when we work in critical care only, we might think we are the only specialists. But having new people coming into the unit who brought something different, who didn't necessarily have the same background, it's opened people's minds. It's welcomed more kind of staffing into the unit. It's allowed them to open up because they've needed to a bit better. So even though things have been distressing and difficult, and we are hearing people feeling empty and exhausted and, you know, bucket full, because they, as Julie said, they're not going home to their normal routine. Some of them are going home to a home school situation, or can't even have 5 minutes to themselves to decompress, or have that cry on the journey home, or whatever we need to do to keep ourselves going. But there has been the flip side of, we managed that well. We did it. We are more cohesive as a team. Look what we're going to bring from this, even though it's been hard, and we've got to talk about what we're leaving behind, because it might come again. This is going to be something we need to hold on to as well. So there's great positivity too.
So how can you spot those staff that are struggling? And I have to say, my personal experience as a manager in this is exactly what you're reflecting. I just probably didn't appreciate in the way you've just presented it there. And but there have been a couple of staff that are struggling. They're struggling with maybe the sheer volume of really unwell people, the sheer volume of the number of people not surviving. And it's what we can do to support people, and how we can how we can either signpost, because not everyone has psychologists on their team. What kind of things might be available in a hospital or in the community, or where do the GP services come into this?
Well, I think, to come to you, Rachel, as a manager, I actually think one of their greatest sources of support is you. Mm-hmm. And actually, lots of the evidence base about well-being in the workplace is about the people who lead us and the way that they support us. I realise a lot of managers I talk to, and for yourself as well, that feels like a huge amount of pressure. But it doesn't actually have to take a huge amount of work. It's just maybe about style and approach. I think one of the big sort of messages that I've put out there, and I've encouraged people in my unit to put out there and in my hospital, is that it's okay to not be okay message. And that's really, really important. I think sometimes when people are distressed, I think we think, gosh, you need to go and get help and get the distress taken away. But actually, distress is part of this. Distress and anxiety is part of how we're dealing with something that, I know the word is overused, but it is unprecedented. And I think having that approach as managers and as peers, people in your team, you see them struggling, and I think it's really important to say to them, it's okay not to be okay. I think it's important to model to them hey, I'm having a rubbish day. I wonder if you have rubbish days too. And just let them know that you're there for them. And I think that's the most important intervention, if you like, that anyone can have, is just that chat, actually. I think then when it starts to become more concerning, I guess as a manager or as a peer, a colleague, what you're looking out for in signs in your kind of workmate is that they're maybe just not behaving in the way that you would normally expect them to. So they might be a little bit quieter, or they might have changed so that they've got a shorter fuse. They might talk about things at home and not being able to function in the same way. So they might talk about their sleep or their appetite or their kind of their mojo and their motivation. So just little things like that are the sort of soft signs that things aren't okay. And that they might benefit from more help, and that help might be lower level conversations, or it might be more of a trained psychologist working with them. Our teams, Debbie and I's teams, are lucky because they've got us, and that's great. Some hospitals obviously don't, but some hospitals do have psychology and counselling within occupational health services. So and most places will let you self-refer to that. You don't need a management referral to that. So that's there. There's been an inordinate number of hotlines set up at the moment, and whatever you think about those are out there, so people can phone through that way. People can get in touch with their GPs. Some of the staff who come to see me, the way they talk about their GPs are being really, really great right now, and really, really accessible and approachable, even if it has to be over the phone and through social distancing and things like that. And GPs are your kind of primary point of kind of referral in to primary care, counselling and psychology services if you don't have that opportunity within your team or within your hospital.
Yeah, I completely echo that about GPs in my experience, and not just for staff, like you said, for patients as well, wanting to know and get, as much information as possible. So, Debbie, we've heard a lot in trust about how people have implemented things like safety huddles, safety briefs, one in the morning, one in the evening, debriefs. So at the end of a shift, the team, the MDT coming together, or the physio team, or the speech and language therapy team coming together and saying how was today, how are people feeling, what is their value in that? People seem to subconsciously be doing that, but what is the value? Why are things like that important?
I think pre-COVID, we should all be checking in with each other and seeing how we cope. Actually, this has forced the issue. So it's not counterintuitive to check in and see how people's days are. We're just doing it more acutely now, and a bit more vocally and a bit more visibly now. So of course there's validity, because actually people might have some good things to say and they might have some tough things to say. And then it, again, as Julie was saying, it kind of points us towards the direction of travel, maybe for different members of staff, the ones that kind of are kind of talking and letting. I kind of always give the analogy of a Coca-Cola bottle. We fizz, and actually are we generally just kind of unscrewing loosely and letting the fizz out bit by bit, or are we fully exploding or just feeling really flat? So by doing these kind of very naturalistic meetings, we're allowing that bit by bit emotional release, so our buckets don't get too full. I think it's a really lovely thing to do, but it is a kind of long-term 365 days of the year thing that we should be doing, actually. When we get into formal debriefs, that's something very, very specialist and needs to be used with caution and following kind of guidelines. But actually any team could be doing that check-in huddle with each other. I think that's a really valid way of working.
And I think, this might be slightly controversial, but I think what is different in COVID times to normal times is that safety huddle, that team brief has become, you've been given permission to do it. And because everyone's so busy and everyone's so important and everyone has to be seeing a patient, there's very few trusts and teams that I've worked in, even being the manager, where I felt comfortable to say every single day you have 20 minutes, 15 minutes, you know, because you're under so much pressure to do work. I mean, what do you think about that? Do you think it's because we have permission to sense check, to self check, to check with our teams? Because this is, you know, this is like you said, Julian, these are, you know, unprecedented times. So
yeah, I think so. I would say absolutely, it's permission led, and actually, probably people like Julie and I have gone around the units for a while, thinking, please talk, and actually, we've become symbolic of that. But now it's become natural and permissive and fantastic. I think Julie would probably say the same.
Yeah, absolutely. And I think, you know, here's the permission, let's take it. And I
Yeah.
think one of the great things, one of the real positives about these times is that NHS staff have been have learned that they can just fly with something and push something. You know, things that would normally take months and months and months of approval before can happen now. So here's something as simple in many ways as a huddle, that often there's this unconscious lack of permission, must keep working, no time for chat before, but we're building it in now. And I think it's good that people are worried about team mental health, and it's good that people are being given the permission for this. Let's make it stay. You know, let's make it part of the routine so that actually it just becomes what we do from here on in.
And maybe it's up to us as the clinicians and as the clinical managers to say, okay, we're not letting that bit go. There's going to be lots of aspects of how we practice now that is different. So actually let this be one thing that we don't let go. And I suppose it's the rebel nature in us. And I think any great system leader actually, you know, realizing the impact and the potential, like you guys have said, this should be normal. This shouldn't be something that is just to be used in this time. So why don't we understand the value, understand the importance, understand that it should be part of our normal everyday practice, and the benefits that we'll have for not only the people, the teams, and the organisation as a whole. I think that's really powerful.
Well said. I think there's something about COVID that's just normalised that we are humans in our profession. We don't have to be professions or professional at work. It's not a separate thing. We are blended identities, and maybe for years we try and be something somewhere else. Psychologists love to kind of look at those different identities, but now we're able to blend. We are the human in the workplace because the whole of our society is going through exactly the same. Long may we hold on to the humanity. We talk about it with patients. We need to talk about it with ourselves too.
So I'm very aware that there might be people, or there absolutely will be people, there will be people listening to this or watching this that have not stopped and thought about their own psychology. And I don't know who coined the phrase psychological PPE, but I mean, it's for me, that summarizes it up really nicely. So we protect ourselves, in other words, let's protect our mental health and well-being. So can you guys think, I might come to you first, Debbie, can you guys think or suggest either a team exercise, an individual exercise, or something that a team, I'm very much for doing things in teams, and it sounds like you guys are advocating that. So is there something that we can sit down to do 20 minutes, half an hour in a lunch break or in some protected time together?
I think there's a hierarchy within the world of psychology called Maslow's hierarchy of needs. And actually, in this fast-paced time, potentially the lower level, which is all about the basic needs of a team or ourselves, actually, the safety, the humanity, eating, drinking, all of those things. Actually, we just need to have breakfast together, or we need to sit down and have lunch, have our team days again, get back into the groove of that kind of non-COVID or COVID, whatever it may be, blended time. But just doing those things together can be really therapeutic. I think the idea of a cup of tea, you know, is worth its weight in psychological gold, in my view, or coffee, depending what you prefer. But or a beer, you know, whatever we need. But obviously not encouraging drinking, but there's something really normalizing about this and being human altogether again. So I would just go with that lower tier.
Love it. Cup of tea and a biscuit. And not just used when people are in distress, because that is often the default. You often wait until someone's at that point where, you know, you say, and I've very guiltily done this in my, you know, earlier years as being in management posts, and it's almost when someone comes to you, you know, crying or distressed, and that's a point where you say, okay, oh goodness, now I need to take you away. But it's about, like you said, that whole prevention, doing things that are normal and ingrained as part of a team. Like I love that, like weekly breakfast meetings, lunch, you know, whatever it might be for your particular team. And Julie, have you got anything to add? Or
It's so hard to follow that, isn't it, really? But I think there is, all the way through, we've talked about connection. And I think wherever you can find connection, find it. So as a team, you find that connection through that common space, having breakfast together. For yourself, you find that connection with who you are and, you know, what drives you as a professional. And I think just finding those moments of connection, just take that moment wherever you can. Don't wait for things to fall apart. Don't wait for signs of things to be negative. Take a moment longer, just a second longer in the corridor. You know, ICU is so fast, isn't it? Take a moment in the corridor, just 1 second longer, to say, oh, hey, how you doing? So important.
thank you. Well, you have both been absolutely incredible. Like, I've learned so much. And if anyone's listening or watching this and wonders why on earth you need a psychologist in your team, we can extend outside of critical care for that statement, that this is exactly why. And Julie, I'm aware that the Intensive Care Society have a fundraiser at the moment, or they have access. Do you want to tell us a quick little sentence about that?
Yeah, so the Intensive Care Society at the moment are leading a big campaign to raise funds for psychological well-being of staff. So that's well-being and resilience through education. So it's not just about education, it's also about potentially being able to increase access to psychological therapies and psychologists within the ICU as well for COVID and beyond. So please give generously if you can.
Absolutely. And these podcasts are all free, so maybe that's a great little, if anyone does want to make a small donation, no matter how small or big, please, we'll make sure we've got the link on the bottom of the podcast. So thank you both so much. You've been incredible. Really appreciate it.
You're welcome.
Thank you. It's been a pleasure.